Ready to go.
All right, I need to continue. Excellent. Well, welcome everybody. My name is Steve Gloyd. I'm the director of the MPH program. I think I know most of you on this call or on this Zoom session, and I'm extremely pleased to welcome you all to the Spring 2020 series of thesis presentations. We'll have thesis presentations for the next 3 days. Today I'm going to introduce them, and tomorrow Bernardo Hernandez Prato will be introducing them, and on, what is it, Thursday is the last day, it will be Deepa Rao. I want to start out by giving a huge thanks to Noura Yusufa, who has organized this fairly substantial effort to get everybody on Zoom and everybody do the presentations in such a way that we hope will be very smooth. So thank you so much, Noura, for all of your work. It's been great. Also thanks to the MPH staff, Julie, Andreas, and Sarah, and thank you to all of you who are attending. It looks like we have over 40 who are attending right now, which is pretty cool. And to all of the thesis supporters, which can be anywhere from the faculty to who are on the who are chairs and who are members, to family members and friends who have helped our students through this process, because it's a really big deal. As you all know, theses are usually between 2 and 6 months of work and lots of write-ups. These are all publishable, so we're very, very pleased and I think honored to have these thesis presentations. So without anything further, let me give you a couple of rules that we're going to have with this Zoom session. We'll have 2 presentations now, followed by a break of 15 minutes at 12:15. Total presentations today are 8, 2, then 6 after that. Each person will have 10 minutes to present and 5 minutes for questions. We'll be keeping track of your time, so we're going to be giving you information or your warning at 5 minutes, 2 minutes, and when it's supposed to be over. And when the 0 minute comes up, please finish as quickly as you can after that, so we have some time for questions. We don't just prefer, we insist that you have questions using the chat box as opposed to raising your hands. We think this will work better. So please use the chat box and we will go through the questions in the chat box to do that. Noura and I will both be involved with that. To remind you all, please be muted during the presentations. You can keep your videos on or off, whatever you want to do. I think it's kind of nice to have your videos on so I can see your faces and your reactions, but whatever. And you're all encouraged to use the reaction function on Zoom, which is, applause or thumbs up or any of that kind of stuff. I think it would be nice. And just so you all know, these will be recorded so people can be looking at them afterwards. So those are some of the rules. Noura, have I forgot anything?
That's it. Don't forget to use the, thumbs up and applause and things like that, because those are always nice for people to see.
Great. So I'm very pleased to introduce the first of the presenters, who is Hunter York of the HME track. Hunter, go for it.
Hi, thanks, Steve. Thanks, Noura. It says screen sharing's disabled.
Sorry, I got you. I'm coming.
We'll make all this work.
Okay, it's working.
Mm-hmm.
Okay, how's that looking?
Fabulous.
Okay, great. Hi, everyone. As they said, I'm Hunter York. I'm presenting my thesis entitled Race, Ethnicity, and Geographic Disparities in Learning Adjusted Years of Schooling in the United States, 2009 to 2017. And we're just going to jump into it. What is a learning adjusted year of schooling, known as a LAYS as well? It is the years of schooling one receives, penalized for the quality of one's education. For example, a student who finishes 13 years of schooling, which is K through 12, but finishes scoring 3 years grade levels behind average would have effectively received only 10 years of schooling. In short, it's learning times schooling. It's part of a commonly used metric of human capital, which is expected healthy working years times LAYS. And it's been detailed in this paper by the World Bank and in a paper by myself and my colleagues at IHME in an international context. It also, I think, well encapsulates SDG goal 4.1, which is ensuring that all pupils complete free, equitable, and quality primary and secondary education, leading to relevant and effective learning outcomes. So in short, it's both learning and schooling. It also has some non-economic uses because we're not just numbers. They allow us to, this metric allows us to examine how inequalities are compounding in both schooling and in learning. Additionally, it's a useful indicator for a critical period in life, which is late adolescence. And education has traditionally been used as a predictor of certain health outcomes later in life, but LAYS could, in theory, be an even stronger one. So this is like fertility, adult mortality, cardiovascular disease, etc. And most importantly, it allows for the comparison of these two component pieces on an even scale, which allows for policy interventions to implement as needed, where it would be more effective to increase either learning or schooling, usually with respect to certain health-related outcomes. And so the data we're working with come available by race and ethnicity year and school district. So this comes from the Educational Opportunity Project at Stanford. This is our learning data. School district population data comes from the Common Core of Data, which is a governmental unit. Population data also comes from the US 2010 census, and median income from the American Community Survey. Additionally, not by race, obviously, we have school district financing data, which comes from the Common Core of Data as well. However, these data are not perfect. As you see on the right, this is on the top mathematics, and then on the bottom reading and language arts. This is the data by grade and by year, and we see that missingness happens in a lot of ways. In some years, whole states are missing. In some years, just certain grades in a district are missing. In some years, even one subject is missing and not the other subject. And this can be for a variety of reasons, but a common one is just due to small sample sizes and privacy concerns. But this causes a problem when we have missing data, because aggregating these data over time and across geographies can cause compositional biases in our outcomes. And so basically we're compelled to impute missing data where possible when we want to make aggregations. And so that's what most of this talk is going to focus on. But before I get to our imputation, I just wanted to cover how we get schooling data. So that was the learning component. And the schooling component is how many years of schooling do students complete. And this comes from our high school stock data. This bottom stuff is demographic notation, which isn't really important to know, but the important piece is that basically if we have population data for a school district over several years and covering several grades, we can basically track cohorts over time to see how many people enter into a cohort and leave a cohort. And the leaving we usually attribute to dropout. However, people can also enter and leave a cohort because of migration. And so we do a simple adjustment to that, which is shown on the right, which is basically where we take the average migration for a cohort, or rather for a year, so not in cohort space, for grades 1 through 6, and adjust the probability of advancing from one grade to the next for grades 9 through 11, based on that like average change in high school stock. And from that we get probability of advancement from grades 9 to 10, 10 to 11, and 11 to 12, and that's how we calculate years of schooling, where we assume that students are in school through the first 10 years and then they start to drop out after that. And then this is an overview of our data, our covariates, and the imputation algorithm that I alluded to earlier. So we have incomplete learning and high school retention data. We have a set of covariates, and we put them through this algorithm to get complete outcomes of interest, which are learning and high school retention data, which we then combine into our metric of interest.
Is the cooler still outside?
This is an overview of the algorithm, which is in two parts, a linear imputation and something called Miss Forest. So the linear imputation part is well suited for subgroup location years with near complete data. So that's like 5 out of 8 data points where we're really just filling in a time series. However, Miss Forest is used for places that aren't so lucky to have such complete data or are missing data altogether. And what's important about it is it allows for an incomplete set of both inputs and outputs to produce a complete matrix of inputs and outputs. And what we want are obviously complete outputs. Also importantly, it allows for nonlinearity and interaction effects between its component parts. And it's a relatively simple algorithm. It just iterates over the columns, starting with the most data-rich column, predicting, and then assessing each iteration with out-of-sample predictive validity statistics and stopping when either a certain number of iterations is reached or when the predictive validity starts to get worse. And here's a paper that details those methods. And here is what we get when we come out the other side of all that data prep and the imputation piece. Top left, we have mean achievement. This is the learning component. This whole slide is just school year 2016 to 2017. The learning component is measured in grade levels above or below the national average. Bottom left is years of schooling. So this is effectively years of schooling on average completed for a district. And on the right, we have the two pieces stitched together as our learning adjusted years of schooling. You'll notice that range of numbers goes from 6 all the way up to like 16.5. And that's because if you finish all 13 years of schooling and you come out the other end 4 years ahead of average, you've effectively received more than that amount of schooling. And I realize that's not intuitive, but that is how this metric is working. I'm going to advance to this next slide so we can talk a little about what we see in the outcome metrics. This is obviously going over time, but the time difference aren't that of note to me, at least. What stands out is the typical north-south divide, which doesn't surprise me, but I am surprised by all this data on the West Coast, which basically shows worse outcomes than I would expect. I would expect most of California and Washington to be like similar to Pennsylvania or New York, but they're not. Additionally, I see a lot of Native American highly populated areas, usually reservations standing out. So the Four Corners area, the Hopi and Navajo tribes. South Dakota has the Lakota people in those bottom two counties. And even in Washington, we have the Yakima Reservation in South Central Washington. And this compels us to disaggregate these statistics by race and ethnicity where possible. So going on to the next slide, I have that done as well as I can at this point. So this is disaggregated by Asian, Black, Hispanic, and white, showing how these inequalities are basically disaggregated by race. And that's basically showing what I've done thus far. Next steps are interpreting these race differences and analyses and creating metrics of inequality within and between states, districts, counties, and races. Some limitations quickly are just obviously limited data availability, lack of clarity on how well these instruments measure meaningful data, similar to how socioeconomic status is commonly not associated with GRE, or is associated with GRE scores, but not really with grad school success. Additionally, these estimates are normative in that white Americans are the most data rich and therefore inform some of the imputation. Right now, no estimates for Native Americans, despite that being obviously a huge group that stands out in the aggregate maps. And so working on all of that, we'll do more. Implications are local health is global health. These are US results, but they can be extended to an international context. But the international learning data are sparse and non-standard. So thank you. I will now take questions and comments and would like to thank my committee, all of y'all, and the people at CSD, Sarah, Karen, and Amy Dactor.
Excellent. Thank you so much, Hunter. This is a fascinating piece of work. And obviously extremely relevant both for the United States and elsewhere. Let me start out with the first question, which is actually the question that I would have had too. So I'll just read this from Bernardo, who asks, have there been studies using the LAYS or the LAYS in developing countries? What information would be required? The metric would be very useful there.
Yeah, so the paper I pointed out at the beginning that I actually am an author on, which was written by some of my colleagues at IHME, basically is a metric of human capital, which uses LAYS as a component piece. And so that was done in an international context. But as of right now, the data is really lacking for a lot of low and middle income countries, mainly because it's really hard to compare tests across geographies. So these tests come from state tests. And even in America, it's very hard to compare like what I took, the Mississippi curriculum test, to the tests in California and in New York. And so the answer is no.
Okay.
Great.
And the second question is one that I just wrote myself to give me the opportunity to ask it, which is that have there been any comparisons between public and private schools, both here? Obviously, we haven't done it overseas, but I would imagine that public and private schools might have some differences.
Yeah, there have been. So these estimates are mainly public and charter schools because it's defined by school districts. But I think a common and obvious discrepancy, inequality is between public and private, where private usually fare better than public. But I think that breaks down a bit when you get into some private schools, which are like correctional facilities in essence. And so I think it does break down, but there are data, but it's usually on a very small scale and not like a national or international context. And definitely not for LMICs as far as I'm aware, except for, I guess LMICs have like a literacy inequality that's often studied, but not so much learning. And those are two slightly different concepts.
Interesting. I'm just going to make a comment that from Bernardo's question and my question, I think that we could be addressing what I consider to be one of the biggest challenges in the next decades of health overseas, which is the quality of public education is really dropping in many places because so many folks are moving to private schools. And I think being able to do this overseas and also comparing public-private, I think would be a huge next step. So just to suggest that's great. And the third question from Kate Cowsey, were there any unexpected challenges as you move from a small sample sizes of data in the US counties as you move to small sample sizes of data in US counties?
Yeah, obviously, yeah, the population masking when you get to really small stuff, just people protecting privacy is really hard. And also the stock data. So if like a cohort is just 5 or 10 students, and the next year that cohort is 7 students, maybe because the students migrated, or maybe they actually did drop out, it gives very noisy dropout rates, which is reflected often in the data in kind of noisy ways. So I haven't done any deliberate smoothing, but like some things have been dropped where sample sizes are just way too small.
Right. Noura, how are we doing time-wise? Do we have time for one more?
We're good. We have time for one more.
Okay, this is from Michael, and I don't have your last name here. Were there any unexpected relationships between the covariates and outcome?
Yeah, so that's actually hard to do with a machine learning algorithm because they don't produce estimates for like beta values in a way that a normal like parametric model would. So I can't actually say, but I did see like if you just scatter the covariates against the raw data, so not in the prediction task, some things that you would expect to be associated with learning outcomes aren't. So, or even like learning outcomes with years of schooling aren't that associated with each other, which very much surprised me. Like I think the highest highs and the lowest lows are associated, but everything in the middle is kind of just a wash. Yeah.
Great. Very interesting, fascinating piece of work, and definitely something that I think needs to be expanded in the future to a lot of other settings. So thanks very much, Hunter.
Yeah, thank you all.
Clap. Everybody can use your clap function now. Okay.
Wonderful. Chang Ling, please take it off. Or
all right.
Continue.
Okay, can you see the slides now?
Yep.
Yes.
Okay, good afternoon, everyone. My name is Chongling Hong. I'm a third-year concurrent MSW and MPH student, and I'm here to present my thesis entitled Sexually Transmitted Infection and Associated Factors Among Men Who Have Sex with Men in China. And my committee members are Dr. Tracy Hirachi and Dr. David Katz. So there's increasing concern about sexually transmitted infections, or STI, among men who have sex with men, or MSM, in China. The prevalence of STI other than HIV were constantly greater than the general population. And as we all know, STI testing is pretty important, as these infections are oftentimes asymptomatic, so delayed screening and treatment may cause further transmission. However, previous studies indicate that the STI rates, testing rates among Chinese MSM was relatively low. A recent cross-sectional study in 7 major cities in China indicated that only about 30% of sexually active MSM had ever tested for gonorrhea and chlamydia in their lifetime. And only looking at lifetime testing is not enough, as we need regular testing to ensure the linkage to care to reduce the transmission. And despite the low testing rate, factors associated with STI testing were not well studied in China, as previous studies mostly focus on STI testing and diagnosis as potential predictors of HIV-related outcomes. So to identify the correlates of recent STI testing can help us to identify the groups of MSM in need of further STI testing services. And lastly, the WHO recommended integrating HIV and STI testing services, which is not the case in China. For example, unlike HIV testing, comprehensive STI testing services are only available in hospital-based clinics. So compare the histories of HIV and STI testing can help us to quantify the missed opportunities and therefore to motivate the integration of these services. So the objectives of this study are, the first is to determine the proportions of MSM who had tested for and been diagnosed with STI other than HIV in the past 6 months. And also to identify the correlates of recent STI testing, and then identify the subgroups of MSM in need of further STI services. And lastly, to quantify the missed opportunity of concurrent HIV and STI testing by assessing the association between STI testing and HIV testing in the last 6 months. So I did a secondary data analysis of a study led by Emory University on Blue to gauge a willingness to use HIV prevention intervention among Chinese MSM online. And Blue is the largest geosocial mobile app for gay men in China, which has, I think, more than 40 million users now. And the survey was conducted in April 2018, and the inclusion criteria were aged 18 and above, male sex at birth, current Blue user, and living in the 4 provinces as shown here in the map, 2 in Northeast China and 2 in Southwest. And for the purpose of this thesis, we included men who reported cisgender men and also HIV unknown and or negative status and had anal sex in the past 6 months. And we used different statistical methods to measure the 3 aims. For the first one, we calculated the proportion of the participants who reported recent STI testing and diagnosis. And for the second aim, we used bivariate and multivariate logistic binomial regression to examine the factors between social demographic characteristics, sexual behaviors, and substance use with the recent STI testing. And for the third aim, we compare STI testing and HIV testing in the last 6 months to quantify the missed opportunity using a McNamara test. So a total of 4627 MSM completed the survey, and 2872 were included in the final analysis. And the mean age for the participants was 29, and with a wide range from 18 to 77 years old. And about 3/4 were reported homosexual or gay, and about 1/4 was reported bisexual. And more than 80% of them had at least college degree, and about 20% were current student. And notably, more than half of them reported always use condom during anal sex in the last 6 months. and more than 40% of them had a history of substance use. And notably, about 60% of them had a monthly income less than 7,000 Chinese yuan, which was equal to $1,000 by the time of the study conducted. And the result indicated that 63.5% of the participants had tested for STI in the last 6 months. And among those who had tested for STI, 13% of them was told by a healthcare provider that they had at least an STI. And syphilis, HPV, or genital warts were the most common infections. And in the multivariate regression, we found that MSM who were older, being employed, or have more frequent condom use, and being in a relationship with either an HIV positive partner or in a monogamous relationship with a recent tested HIV negative partner, and has a history of substance use, were more likely to get tested. And lastly, we found recent STI testing was strongly associated with recent HIV testing. First of all, the lifetime HIV testing rate was about 75%. And among those 1428 individuals who tested for HIV, about 57% of them also tested for STI. And among those who tested for STI, about 85% of them also had tested for STI, HIV in the same period of time. So in summary, we found that only about 1/3 of the MSM in this study have been tested for STI recently. This is remain low, especially comparing with the HIV testing rate in this same sample. And we found that MSM who are older, being employed, or had more frequent condom use, has a history of substance use, and in an ongoing relationship were more likely to get tested for STI. And we do find the missed opportunities for STI and HIV concurrent testing, as almost half of those who reported HIV testing had not been tested for STI. And about 1 in 6 men who reported STI testing had not been tested for HIV. And there are several limitations of this study. First, MSM were recruited through the geosocial map online in 4 provinces in China. So the generalizability of the result to the geographic regions in China and to those men who don't use blood is uncertain. And also, our result and data were self-reported, and therefore they're subject to social desirability bias and recall bias. And also asking for the question of STI testing, we ask participants whether they have been tested for STI. So this may not reflecting the frequency of STI testing in a longer period of time. And in summary, our study provided insight into STI testing behaviors and evidence to inform the development of intervention, especially for policy, as currently there are no formal STI testing guideline for MSM or even the general population. And we found that recent STI testing was less common among young MSM and students, which indicates the need to further ways and interventions to promote STI testing among these groups. And there are substantial missed opportunities to provide comprehensive sexual health services, such as integrated HIV and STI testing. And lessons from the successful HIV testing intervention of the last 2 decades in China, and leveraging existing HIV testing to offer STI testing had the potential to increase the STI testing among the population. And we suggest that further research and future research should examine the barriers and facilitators to STI testing, and also develop and evaluate interventions to promote STI testing among Chinese MSM. And with that, I want to thank my committee and my collaborators from Emory University and in China. And I want to express my special gratitude and appreciation to Dr. Diakhate, who helped me to connect with the research team in Emory and to make this happen, and also provided tremendous help on data analysis and the development of the paper. And with that, I think it's 10 minutes, and I'm open to any questions. Thank you.
Great, thank you very much, Zhonglin. That was really well done. I don't see any questions on the chat box, so I'm going to take the liberty to ask one, which is that I was actually kind of impressed that the testing level or the testing rates seemed fairly high. That is 33% of them tested, within 6 months. Do you think that this is a group that's significantly different, say, than the general population of MSM by being part of this BLUID, program? Is there any way that you can kind of compare the sort of demographics of this group versus the general population?
Yeah, as I mentioned, this study was conducted in the 4 provinces, 2 in Northeast China and 2 in Southwest China. I think at first the parental study may want to examine the difference between the geographic differences in these areas. And also, these MSM were recruited by on the online platform. So I think BLUID as a software, they may constantly doing some like sexual educations, promote HIV and STI testing. So I would say at some point or at some level, the generalizability is uncertain. And but I think on the other aspect, the study population has a wide range of age from 18 to 77. So I think with a very equal distribution actually. So I think in that dimension is quite representative.
Okay, great, thanks. There are a couple more questions. One is by Michael. Were there any unexpected relationships between the covariates and the outcome?
Steve, that was the last.
Oh, that's the last one, I'm sorry.
Anne.
Okay, this is Anne. Okay, great presentation. I'm curious to know why the incidence of chlamydia is low while that of syphilis is high for the study population. How is the annual screening for STI like in China? What STIs are typically tested?
For the first question of why the incidence of chlamydia is low, I'm not sure. But for the STIs were tested, normally, as far as I'm concerned, especially I used to work in an infectious disease hospital, mostly people will only get tested for syphilis. And recent study also found that a lot of physicians will not prescribe STI testing even though the patients asked. So I think from that aspect, there are some missed opportunities to offer comprehensive testings about all those infections as well.
Okay, thank you. And then a question from Renee Heffron. Were there any of your results that you found surprising?
Yes, I think, as I mentioned here, I'm not sure whether I can still share the slides here. Like here, we found quite a big proportion of participants had a history of substance use. And this is actually positively associated with STI testing. And based on my literature review, sometimes the history of STI testing is negatively associated with HIV testing. So I think further research should examine this factor to see what happened here and what's the relation between this factor and testing services. And also, I'm surprised to find that young MSM were less likely to get tested because as I mentioned, a lot of young MSM using this sort of dating app, and they're doing constant work on disseminating sexual health services. So I thought that young MSM will be more likely to get tested, but it turned out that they're the least likely to get tested.
Okay, very interesting. All right, thank you very much, Zhonglin. That's a great presentation. And with those two presentations, we're finished with our first group. And I believe we now have what could have been a 15-minute break, but now is
10-minute.
about an 8-minute break.
Yes.
Is that right?
Yep,
I think we
exactly.
should start on time. So if people don't mind just waiting 8 minutes, and we'll reconvene. Can people stay on, Nura?
Yes, please stay on. We'll be starting at 12:30. Well, two minutes before, if you could come back.
Okay, sounds great. Thank you very much. Hello. Nura, are we ready to go?
Yeah, we can go ahead and get started. We're a minute early.
Should we start a minute early or should we wait? Let's wait.
Okay. Oh, it's 12:30, so it was only a few seconds.
Okay. So welcome back, everybody, to session 2. This is the longer session where we have 6 presentations, one after the other, between now and about 2 o'clock.
Yep.
So once again, a big thanks to Nura for setting this all up, and a big thanks to all of you who are going to be presenting. I'm very excited. So let's start out with Marem Diakhate.
Okay, so let me share my screen first. Okay, can you all see?
Yep.
Yes, we can.
Great. Thank you. Hi, everyone. My name is Marem Diakhate, and today I'm presenting my thesis titled, Correlates of Breastfeeding and Infant Health in Kenya. So we're going to start off with our background. Breast milk is the optimal food for infant, and it has anti-inflammatory and immunological properties that are beneficial to the infant. Not breastfeeding or shorter duration of breastfeeding has been shown to be an important consequence on infant health and risk of malnutrition. The World Health Organization recommends exclusive breastfeeding, which is defined as only feeding the infant breast milk for the first 6 months of life, followed by continued breastfeeding with introduction of other foods. However, only 40% of infants are exclusively breastfed during the first 6 months of life. In a previous study, mothers in low-income communities in Kenya reported it is difficult to adhere to feeding recommendations if the child is also being taken care of by other family members or neighbors who may feed the child other foods in the absence of the mother. Adhering to the recommended feeding guidelines is especially difficult in communities where exclusive breastfeeding is not the norm and mother does not always have the autonomy to choose how to feed their child. In communities with high HIV prevalence, stigma and others suspecting a mother may be HIV positive have influenced a mother's choice to not exclusively breastfeed, especially if they have not disclosed their status. However, it's been reported that attending healthcare visits and having contact with the healthcare facilities does encourage mothers to continue adhering to the recommended feeding practices. Despite these reasoning, though, it is still not clear what influences mothers to adhere to the recommended feeding guidelines. Thus, using results from a national survey, I conducted a cross-sectional study answering 2 questions. The first one was examining the associations between socio-demographic characteristics and HIV status and breastfeeding practices among women at 6 weeks and 9 months postpartum. And in the second one, examining the relationship between breastfeeding practices and infant growth at 6 weeks and 9 months. Now I'm going to discuss the methods we use for this study. Before I start, I would like to acknowledge that I am an outsider of the communities that our survey population are coming from, and I am a Senegalese American and a graduate student in a Western institution. So my study, again, is a cross-sectional study, and it uses a secondary data from the 2013 Prevention of Mother-to-Child Transmission of HIV in Maternal Child Health Survey. This survey has 2 parts. The primary survey was conducted in 120 randomly selected facilities across Kenya, and the second survey was conducted in just 20 clinics in the Nyanza province, which is an area of high HIV prevalence. And this second survey focused only on HIV-infected mothers. Both surveys enrolled mothers and their infants who were attending their infant's 6-week and 9-month immunization visit. For our first aim of maternal social demographic factors and health characteristics associated with breastfeeding, we chose maternal depression as defined by the PHQ-9, education, marital status, and HIV status as our exposure of interest. For our outcomes, exclusive breastfeeding among infants in the 6-week group and continued breastfeeding among infants in the 9-month group.
Yeah.
And then to measure continued breastfeeding in the first 6 months of life, we measure exclusive breastfeeding during the first 6 months among the 9-month infant group. For our second aim, our exposures are the outcomes of aim 1, and our outcomes of interest were underweight and wasting. We use generalized linear models to measure the association between the exposures and outcomes of interest. To account for clustering at the facility level survey design, we use facility level clustering. Now I'm going to share with you all our results, starting with our maternal characteristics here. The age of mothers, as you can see, was pretty much 26 years old in both infant age groups. For education, majority of mothers had a primary education or lower. Over 15% of mothers in both groups were HIV infected. And also, most mothers reported having financial support from a partner or father of the infant. Lastly, 10% of mothers, over 10% of mothers actually, reported experiencing mild depression or above. This table outlines our breastfeeding practice characteristics. As you can see here, almost all mothers reported currently breastfeeding. Same with the exclusive breastfeeding among the 6-week group here. And then most mothers also reported exclusively breastfeeding their infants during the first 6 months of life. Now I'm going to present our results for aim 1. And this is the first part of our aim 1, which is the association between maternal factors and breastfeeding practices for the 6-week group. As you can see here, after adjusting for maternal age, education, HIV status, we found a slightly lower prevalence of reported exclusive breastfeeding among younger women and those with primary education and below. Interestingly, though, we found slightly higher prevalence of reported exclusive breastfeeding among HIV-infected mothers. Next is our second part of our aim 1, which is the association between maternal factors and currently breastfeeding among 9-month infant group. Here, after adjusting for maternal age, father-partner support, maternal depression, and HIV, we found 12% lower prevalence of reported currently breastfeeding among HIV-infected mothers. And then lastly, this is the third part of our aim 1 result. And this one is the association between maternal factors and exclusive breastfeeding among the 9-month infant group during the first 6 months of life. Here, after adjusting for education, maternal depression, HIV status, we found 13% lower prevalence of reported exclusive breastfeeding among mothers with primary education or below, and a 17% lower prevalence of reported breastfeeding, exclusive breastfeeding among women with mild or above depression. We again found a 27% higher prevalence of reported exclusive breastfeeding among HIV-infected mothers. Now I'm going to talk about our infant characteristic table to tie it into our aim 2 result. Here, over 15% of infants were HIV exposed. 9% of infants in the 9-month group were underweight compared to 6% in the 6-week group. Lastly, over 10% of infants were reported to be wasting. This is our aim 2 result, which is the association between breastfeeding practices and infant growth. We found a 62% lower prevalence of underweight and 44% lower prevalence of wasting from in here in the right and the left here, comparing mothers who reported exclusively breastfeeding their infants compared to those who didn't. We also found a 52% lower prevalence of underweight for infants who were currently breastfed. Among the HIV unexposed, we found a lower prevalence of underweight among infants who were reported to be exclusively breastfed. Moreover, we found a 51% lower prevalence of underweight among infants in the HIV-exposed groups who were reported to be currently breastfed. We did have some limitation of this study due to its design nature. As a cross-sectional study, we can't assume temporality as all data were collected all at once. And because it was a survey design, we do run into issues of bias due to self-reporting, especially when it comes to reported breastfeeding practices. Lastly, it is a facility level based survey. So mothers who come to the facility may be different than mothers in the community. However, uptake of immunizations at 6 weeks is high. Now I'm going to discuss our conclusion and discussion here. We did notice that HIV was an indicator of higher exclusive breastfeeding at 6 weeks, as well as during the first 6 months of life, and of lower prevalence for currently breastfeeding among the 9-month group. Additionally, among HIV-exposed infants, we noticed lower prevalence of underweight among the 9-month group who were currently breastfed. Many HIV-infected mothers attending health facilities are trained and educated on the recommended feeding practices, and we wonder if this could be the reason for this high prevalence of exclusive breastfeeding. But the question of why currently breastfeeding is low among the 9-month group remains. We also noticed that primary education or lower was associated with lower prevalence of exclusive breastfeeding in the 6-week group, as well as in the 9-month group who exclusively breastfed during the first 6 months of life, which is exactly what we hypothesized. Given these results, more research to understand specific maternal factors that influence breastfeeding practices are still needed, especially in low-income countries and settings. More importantly, continue education and training of breastfeeding practices after the first 6 months of life for HIV-infected or exposed mothers are needed. I would like to thank my thesis chair, Dr. Christine McGrath, and my thesis committee member, Dr. Jennifer Unger, and all these teammates from Kenya and in the UW and CDC. And thank you all for your time. And now I open it up for any questions or comments you may have.
Very nice presentation. Thanks, Mimi.
Fabulous.
Any chat questions? I think it's from the last one. So let me just start with one since I haven't had time to write it. I was impressed that the HIV group was, had better exclusive breastfeeding, although it seemed like perhaps the number of visits might be, numbers of clinic visits might be more in the HIV group. Did you look at number of clinic visits, both with HIV and the other groups, to see if that was associated with the proportion of exclusive breastfeeding?
No, we did not look at that data. I don't think we had that data, but it is an assumption that exclusively HIV exposed mothers who do attend the facilities are trained and educated a lot about breastfeeding their infants, especially with the WHO guidelines.
All right. Thank you. Polly said, great job. Abakar said, great job. And let's see, we have a question, I think, from Bernardo. It was interesting to see less breastfeeding in lower education groups. Any possible education of this?
Any possible explanation? Is that the
explanation question? Of the lower breastfeeding, or less breastfeeding in lower education groups?
I haven't run into any clear explanation, but assumption can always be less education and less ability to read and write. So maybe that might be a reason for it. Or it could also be tied to lower access to health facilities. But that's something I do want to look into a little bit more, and I'm sure there are reasons for that. But that was a really interesting finding we found for us.
All right, you got a lot of bravos and great job. And then there's another one. Did you all look at employment as a correlate?
We did. Well, not as a correlate. We just used it as a characteristic, but we didn't use it as a correlate. We looked into other different factors that we can assume, like such as education, that we can assume can also be related to employment.
Good. And then finally, one more question, Noura. Can we do it?
Go ahead. More.
This is from Sarah Smith. Great presentation. I may have missed this, but was there a distinction between first-time mothers and presumably non-first-time mothers?
Good question. Yeah, we didn't use that in our data analysis, but we did look into those also.
All right. Any
Great.
other questions? GM says, wonderful presentation. All right. Thanks so much, Maram. Great job.
Thank you. Stop sharing.
Okay. Next up, we have Diane Kendall.
Yay.
All right, is the screen share on proper?
It's nice.
Wonderful. Hi, everyone. Thank you for tuning in today for my presentation on the development of a graduate program in rehabilitation sciences in Ghana. This is a case report about a global health academic partnership. Before I get started, I'd like to thank my committee, my chair, Stephen Gloyd, committee members, Carolyn Baylor and Bernadette Williams-York from the University of Washington Department of Rehabilitation Medicine, and Sonia Bawaji, who is faculty at the University of Health and Allied Sciences in Ghana. The Global Health Academic Partnership in this case study is between the University of Health and Allied Sciences, which is located in the Volta region of Ghana, and the University of Washington. UHAS posted an advertisement internationally where they were soliciting support for their current undergraduate program in speech and hearing sciences, and they also wanted to do work on building a graduate program. I responded to their advertisement, and following several emails and video meetings, it became clear that a partnership could be formed around the unifying goal to develop an academic master's program in rehabilitation sciences. So for those of you who aren't familiar, rehabilitation sciences is an interdisciplinary field with occupational, physical, speech-language therapists, and also prosthetics and orthotics. And these are folks who work on the prevention, assessment, treatment, and adaptation for both children and adults who have disabilities. There is a need for rehabilitation specialists worldwide. The 2004 Global Burden of Disease report estimated that 18% of the world's population has a disability. And regarding social determinants of health, disability disproportionately impacts vulnerable populations in low-income countries relative to high-income countries. And there are few trained rehabilitation professionals in middle and low-income countries. In fact, one of the lowest densities of rehab professionals worldwide is in sub-Saharan Africa, with many countries having less than one worker per 10,000 people. Global health academic partnerships involve complex and dynamic relationships between nations, people, and institutions. When they are done effectively, global health academic partnerships have the potential to leverage resources from the power and privilege in high-income countries to improve healthcare in low or middle-income countries. That being said, there's a gap in the public health literature pertaining to global health academic partnerships. Funding agencies and publication requirements demand outcomes about the product and output of the programs. And there's not a lot of work dedicated to measuring the quality of relationships and even hoping to identify predictors to successful partnerships. So the purpose of this case report is to outline a description of one particular partnership and hopefully to provide some early lessons learned. Now for the methods. Information for how the Global Health Academic Partnership was formed will come from my personal experiences, memories, reflections, interactions. And information for lessons learned will come from an electronic survey that was sent to 7 faculty members who were involved in the working group with 4 open-ended questions. 2 questions were developed to tap into the construct of describing the experience of working in the partnership. And questions 3 and 4 were aimed at what they thought about the quality of the project and if it met their expectations. Survey results were analyzed using an inductive coding technique where I closely read the text, then I identified text segments that contain meaning units, created a label for a category into which the text was assigned. So for example, of a question talking about your experience, the respondent said, initially there was a challenge with the video conferencing, but later we made a lot of headway for the meeting. So the text segment challenge with the video was labeled and put into the category for communication. Now for the results. For objective 1, which was the description of the partnership, UHAS posted a position for program support and development, and I responded. The Dean of UHAS formalized the relationship with a visiting scholar appointment. We mutually agreed upon the goals to develop a Master's of Philosophy program in Rehabilitation Science. Between September and March, we worked together via email, video meetings, and through a shared Google document. The agendas for the meeting were mutually set, and the meeting notes were stored on a Google Drive that was easily accessible by all. To demonstrate need for the Masters of Philosophy program, I researched the quantity and details of MPhil and PhD programs in rehab sciences in North and South America, in Europe, Asia, Oceania, and Africa. The data from that research served as a basis for the MPhil program development. Now, of course, my thesis is focused on the relationship, not the product, but my committee will see the entire program in the appendix of the thesis document. Now for the results from the survey to address the objective 2, which is lesson learned. 5 out of 7 faculty responded. The first question asked the team to describe their experience using during the development of the MPhil program. All group members reported that they entered the relationship with high expectations and that the experience was positive. Regarding the quality of the relationship, positive themes emerged related to equality. Here are a couple of comments from the survey. For question 2, how could the experience have been better? The theme emerged around communication, in particular poor communication, in that the virtual connections detracted from the experience. Clear role assignment was needed prior to the start of the project, and stronger relationship building could have occurred before the project was started. Here's some feedback that spoke to these points. For question 3, all respondents reported that the MPhil program quality was good. And the last question asked, to what extent does the MPhil program meet your expectations using a Likert scale of 1 to 5? Results showed that the final program product met or exceeded the expectations. Now for the discussion. The work presented here is consistent with prior work in global health academic partnerships, as it represents level 1 evidence, which is a coherent description of what was done with a clear rationale. Citron and his colleagues described a partnership between the Ministry of Health in Nepal and a nonprofit healthcare provider in California. They assessed the quality and effectiveness of their partnership utilizing something called the Tropical Health and Education Trust Principles of Partnership Framework, or the PHET principles. Our results lined up with 3 principles. First, the partnership needs to be strategic upfront and before the work ensues. I was formally offered the visiting professorship for the program development, and this forced us to define project goals and our time frame. Second, the partnership needs to be aligned with local and national plans. We were aligned with the University Ministry of Health goals to develop academic programs that will train the next generation of healthcare providers. Third, Responsibility speaks to the activities inside of the healthcare partnership. While the dean, one lecturer, and I developed a trusting relationship, the comments from the survey indicated that because I was not on site for the work and that the larger working group wasn't involved in the project from the start, trust within the team did suffer. OKK talked about an issue called temporality, in that these global health academic partnerships have the capacity to actually cause harm to individuals and organizations long after the high-income partner leaves. And this harm is due to the lack of infrastructure or managerial expertise or administrative capabilities to sustain the project long after the high-income partner returns home. And this is the case, this is the problem in our case. We plan to do a Fulbright grant to continue this work in academic year 2021. However, due to COVID, that will not occur. That being said, the deans offered financial and housing support for me to come to finish our work following COVID travel restrictions, and this does speak to the quality of the partnership and the desire to continue. Finally, regarding limitations and next steps. First, the work presented here is really only a descriptive study. Future work needs to measure the effectiveness of global health academic partnerships. You have to include a framework such as maybe the THET framework for one. Second, it's only a survey and the sample size was small. Future work should employ a purely qualitative approach with in-depth interviews conducted by persons not involved in the study. Third, the work was conducted remotely and this greatly impacted relationship building and communication. It's hopeful for future work to be done in person. Finally, my positionality of being a middle-aged white woman with a Western education and university employment who is monolingual English had both the potential to negatively and even positively impact the partnership. Thank you. I'll now take your questions.
All right, very nice job, Diane. We have one question already up, and that's from Awa Kone. Nice job, Diane. Too often partnerships between high and middle or low income countries have shown to be unequal, more advantageous to high income countries. How do you envision this partnership to be different, that is more equal?
That's a great question, Awa. I think this partnership, in some respects, doesn't have the capability to be that different because we are restricted largely due to travel. I'm here, they're there, and you can see there isn't a lot of trust. I think what's helpful is that because I have a faculty position in the rehabilitation sciences, that helped in some way to gain a lot of respect with the dean and the other faculty members versus me being a student just getting started. Thank you.
Great. Well, there's a bunch of great works. Nice job from about 10 people, but I want to read one from this woman, this person named Nia Kendall, who says, I'm so proud of you, Mom. Amazing job. So articulate. So when you get your daughter giving you those kind of comments, you know you've done well.
Oh.
Let me ask you a question from myself, having been involved with this. First of all, great job. I think you really brought out a lot of stuff. What were your surprises, or perhaps upon reflection, the missteps that you think you might have made, during this process, and how might you have done it differently?
Yeah, the biggest misstep was brought out in the survey, Steve. I was under the assumption the dean, because he selected this working group, kind of top down, selected this group to come together. I was under the assumption that he did a full and complete introduction of me, who I am, what we're doing, how we're going to work on this over a year. We're planning for this Fulbright to continue. And as it turned out, it didn't really happen that way. He was removed after he convened the working group. He was really removed. And it was Sonia, the lecturer on ground, and I. And that was a big misstep. I wish I would have had the opportunity to meet with the working group just really, really early on in the process.
Excellent. Thank you.
Mm-hmm.
All right. Any other? I think we just have a bunch more well dones.
Steve, there's one question from Carolyn Baylor, who
Okay.
says, I'm curious about the relationship between unclear role assignment and trust. Any thoughts? Oh, and great job.
Yeah, Dr. Baylor, thank you. She's on my committee. I think, Carolyn, that speaks to what Steve just brought up. I think they were told to come on this group. They weren't sure who was leading. They weren't sure how the agenda was set. And they were just a little unclear in the process. Are we just doing the MPhil program? Are we going to continue on to a PhD program? And they just didn't get a firm footing. Then when we got together in these virtual connections, it was a bit disrupted. So I think that's a little bit behind that. Great question.
Nura, time for any more?
That's it.
That's it. Well,
Thank you,
Diane.
everyone.
Great job.
Great job.
Okay, next up we have Jason Hips. Jason.
Thank you.
Okay, let me see here. Okay, good afternoon, everyone. Can you see my screen okay?
Yes, we can.
Okay, my name is Jason Hips, and my thesis topic today is modeling dengue transmission risk in Central and South America using climate data. Dengue fever is a mosquito-borne disease caused by the bite of the female Aedes aegypti mosquito. In severe form, dengue fever, also called dengue hemorrhagic fever, can cause severe bleeding, drop in blood pressure, shock, and even death. Countries in the Americas have experienced a threefold increase in incidence over the last 3 decades. The expansion of dengue has consistently been increasing due to factors of climate change, globalization, trade, socioeconomic settlement, and the virus's evolution. A large number of dengue cases are being reported in Central and South America. Both Brazil and Colombia, which are included in my study, are reporting some of the highest cases of dengue in the world. So far in 2020, Brazil and Colombia are at the top of the world's list for cases of dengue. Currently, there's not an effective vaccine, so addressing the danger through awareness and public health interventions are the only way to combat this threat. So my power, privilege, and positionality includes the fact that I am a white non-native speaker, resulting in my data often being translated. Also, I do not share several of the social and economic characteristics of the population at risk. My first thesis aim was to assess the seasonal change in the geographical risk in human population at risk of dengue virus infection in Brazil, Colombia, and Costa Rica. My second aim is the development of a capable model in assisting and predicting dengue virus across the Americas. So this is my conceptual model. The conceptual model on the screen shows the overall theme. I was looking for the association between the historical human cases of dengue and the environmental factors impacting the mosquito survival. The cross-section labeled association of interest is the focus of my thesis. The study design. This is a descriptive study and was a secondary longitudinal data analysis for Brazil, Colombia, and Costa Rica from 2007 to 2018. I used confirmed dengue reported infections and meteorological conditions as the input for the study. So this is my data collection chart. As mentioned in the study design, the data included human and meteorological data. The data was collected at the administrative 1 level, which is the governmental structure just below the national level. For example, in Brazil, it was states, Colombia, it was departments, and Costa Rica was provinces. For the human data, confirmed cases of dengue virus in population was extracted from open source national databases. These cases were collected on a weekly frequency and the population yearly. For the meteorological data, it was taken from NASA's Global Land Data Assimilation System. The temperature data was taken at weekly intervals and was used to calculate the EIP, which is the intrinsic incubation period. This is the incubation period of the dengue virus within the gut of the female Aedes mosquito. The weekly temperature and humidity data was calculated, was used to calculate the daily adult mosquito mortality. The values were used to calculate the probability that the mosquito survives the incubation period, which is labeled as the risk index. I will refer to that throughout the briefing. This is my data analysis for the dengue human case rate. The chart portrays the dengue human case rate for the study period. The study year, the total population for each administrative 1 unit, the number of human cases, and calculated per case rate per 100,000 population at risk within each country. The note is that Brazil and Costa Rica did not have human cases available for some of the study years, which is one of the limits of this study. The risk index, this is a graphic, is an example from Colombia, one of the countries, which is the probability, the risk index reminder is this is the probability that the mosquito survives the incubation. This was graphed for each country at the level of an admin 1 over the study year by weeks. The figure illustrates the seasonal environmental trends and rise and fall of the probability that the female Aedes mosquito will survive the incubation period. You'll notice that the trends are up and down based on different times of year. This is going to be essential for the predicting. After the case rates and the risk indices were calculated, I developed a model for each country, as well as a combined model. I created a logistic model by using the weekly risk index and the dengue incidence rate at each admin level 1. The dengue incidence rates were modified using logistic regression, with a transformation of 1 being the presence of dengue, which translated to greater than or equal to 0.5 per 100,000, and 0 is 0.5 per, is less than 0.5 per 100, as being little or no transmission. The training to testing ratio of the model was 2/3 training and 1/3 testing. The output of the logistic regression model provided the probability of dengue cases occurring at a specific risk index value. And this is the combined model graphic based for every 0.01 increase in risk index, the odds of dengue being a 1, the blue line at the top, increased by 23%. This outcome also carried a similar trend as the independent country models. This confirmed that the larger the risk index, the greater likelihood of dengue transmission. The combined model also proved to be the best model to be used in other regional countries due to the combined country characteristics and data. This chart is the results of the individual country models, as well as the combined model. First point to highlight is the accuracy rating. All of the models performed well, with the exception of Costa Rica. Costa Rica had an accuracy rating of 53%. The models produced a very small p-value with a high significance. The graph also showed the intercept and coefficient values. Finally, as an example, using the combined model rho and the risk index again, for every 1.01 increase in risk index, the probability the mosquito will survive past the incubation, the odds of dengue being 1 in the model is increased by 23%. As part of the discussion, for the strengths, the combined model proved successful and is regionally generalizable. There were several limitations. There is possibly inconsistency in case reporting, as with most diseases, reporting and underreporting with common symptoms. As evident in the data, some country-reported data sets were limited. The study also does not include non-environmental factors that may impact infection acquisition, such as social factors and standing. Finally, as discussed in the results, the Costa Rica model did not perform well. There are several implications gained through the study. One is that seasonal dengue predictability, both regionally and locally, can be gained through this model, which in turn aids public health planning and resource allocation. To conclude, the developed model has the potential to be utilized in future studies throughout the Americas. I want to say thank you and acknowledge my thesis team and support team. Professor Christy Ibai served as the chair of the committee. She has been an amazing mentor throughout the thesis development and through my time at UW. Professor Corey Moran has not only served as a committee member, but he's also been the project lead and the subject matter expert for this topic, and he's guided me a tremendous amount. And thank you to Major Karina Resta, who translated the documents from Spanish and Portuguese to English. And my friend Hung, thank you so much for being my peer advisor and helping me with all things coding and biostatistics, because I struggled at times. And here are my citations, and thank you very much. Any questions?
All right, very nice job, Jason.
Thank you.
I don't see any questions here, so I'll start out with one, which is you have 3 countries, and one of them didn't work out very well, but the other 2 worked out well. That's a little concerning. Plus, I noticed that when one of the tables you showed, which I wasn't able to sort of see real clearly, but it looked like the annual change in dengue outbreaks was enormous, like doubled one year from the other.
Correct.
Is it, what makes you pause when you see that, given the fact that you're not going to get those kinds of changes in your temperature and your other sort of aspects of environmental effects on the mosquitoes?
Right. I did notice that when doing the calculations. One of the things, that's the great thing about using logistical regression, is that if it was over the 0.5 per 100,000 anyway, it was already going to be coded as a 1. So it kind of plays into that effect. And it goes back to the limitations as well, where some of the reporting was kind of sporadic. And that's why using the combined model, it alleviates some of the inconsistencies in the data. Steve, I'm not sure if I answered that question.
So why does Costa Rica not do as well? I would think that Costa Rica's reporting would be actually quite good, given the healthcare system that exists in Costa Rica.
Well, I've looked into that, and part of the problem might have been with their population distribution. They realigned during this study period as well. And once I got into it, so some of the double reporting or not reporting of population and cases may have skewed the model, the results. And I spent more time on Costa Rica than I did with Brazil and Colombia trying to figure that out. And I did not actually come up with a true answer.
It's almost always more interesting to try to figure out what doesn't fit than what does.
Yes, sir.
Bernardo asked an interesting question. Have you had a chance, or are you planning to share your results with local stakeholders? Any reactions? How can these data be used on their end?
Well, the plan is that with Professor Moran, this is going to be rolled up into a larger project that he's going to be working with. And I know he's going to be rerunning some of these numbers again. And I know at that time, this is a product that will be going back, but this is one piece going into a larger project that will be shared with the stakeholders to the best of my knowledge.
All right. Any other questions or comments? Well, thank you very much, Jason.
Thank you.
Really interesting.
Good job,
piece of
Jason.
work.
Thank you.
Okay. Can we go on, Nura?
Let's
Our
go,
next-
Steve.
Our next is Obiora Okoye. And Obiora must be, I haven't seen you here, but
Yeah, I am here, Steve. Thank you so
there
much,
you are.
everyone.
Excellent. Hi, Obiora.
Yeah, hi, Steve. And hi, everyone. One moment, I'm going to share my screen. Yeah, can everybody see me and see the screen? Awesome. Thank you, everyone. And thank you for joining us today. I want to, first of all, thank my thesis committee. And I want to thank Aaron Kass for his patience and flexibility while, I work out the whole thesis. And I equally want to thank Jeff and very important, Kenneth Shah. I like the fact he called this work monumental. And one of my external members, Dr. Omar Martinez. I want to thank them especially for that, the work and the support. So I'm going to start. This is my outline, background, method, finding some of the unanswered questions, and conclusion. So a little bit of a background. So prior to the COVID-19 pandemic, globally, unauthorized international migration and equally authorized and unauthorized border crossing were on the rise, especially from developing countries to more economically developed countries within the global north. And the surge in migration had led to changing demographics, increased anti-migrant sentiment, and hostile policies towards non-citizen migrants within the global north. Receiving countries instituting policies at multiple levels to restrict non-citizen migrants from accessing public benefit, including healthcare. And these exclusionary policies have been widely investigated and noted as a determinant of poor health and clinical outcome among non-citizen migrants. However, migrant inclusive policies get towards mitigating the unintended and intended consequences of unequal access to public benefit, including healthcare, for non-citizen migrants are understudied. And so that's why we did this work. And this is my conceptual framework that we put together. At the end of the day, it's all about, because most people in the United States and everywhere, people were mainly migrants at some point. A report by Joseph et al. Of Oxford University showed that previous waves of migrants to the global north, particularly European colonizing the Americans and Australia, were greater in number compared to the current wave. So there's a disconnect when people move to a certain area and they switch. They either become permanent residents and citizens and start ordering other people, right? And those discrimination, we could see it clearly with the COVID-19 situation where Black and brown people are highly affected, and the rate of death is really high. And there's manipulation and white supremacy written all over these things. And academic institutions, various platforms, various sectors in the country actually ignore what is going on. And it just kind of turn a blind eye to it and tacitly supports what is going on, which is really unfair. We have a tendency to brand other people when we want them as immigrants, and when we don't want them immigrants, but when we want them, they're essential workers, so which is really very ridiculous. So, and when we look at what's going on, this affects various generations over time. So with inclusive policy, what it helps us do is to prevent this intergenerational trauma that's actually over time has been inflicted on generations of people, mainly Black and brown people. I mean, some Europeans too, but most recently is mainly Latinos, that are, the scapegoats at this moment. So we wanted to find out what the current evidence is on inclusive policies on health and clinical outcome of recently arrived and undocumented migrants within the global north. And we started with operationalizing our terms, understanding who's a migrant. So we used the definition of the United Nations agency, the International Organization on Migration. And they define a migrant as anybody who is moving or have moved across an international border or within a state away from his or her habitual place of residence, regardless of what caused the movement, the person's legal status, what the length of stay was, whether the movement is voluntary or involuntary. So, and it was a systematic review, and this systematic review was conducted in accordance with the preferred reporting item for systematic review and meta-analysis, PREMA guideline. And we searched through 3 electronic databases, the PubMed, Sana, and EcoHost, for English-only peer-review publication conducted in the global north between January 1998 and 2008. We used the digital tool Covidence Systemic Review online management platform for data extraction. Yeah, I worked with 2 librarians, one at the University of Berkeley and one at the University of Washington, to work on the search strategy and our selection criteria. And our inclusion criteria includes at the policy level, descriptors of inclusive policy. They go by different names across different countries. And we actually targeted mainly non-citizen, newly arrived, and undocumented migrants. This was really very difficult to get the data because data on migrants sometimes are not really disaggregated. And some of them, there's sensitivity around that data collection. So that was a major problem for us, but we tried the best we could. So started with about 8,318 articles. And at the end of the day, 23 were included in the final study. And so we looked at them across health and clinical outcome, right? Our finding on maternal and child health was really mixed. Some mostly positive, but there were some neutral findings, especially with respect to child health. Authors mentioned that it's difficult to really understand the short-term impact or health outcome among children. So that was really difficult for them to calculate. So they left some of them as neutral. But for mental health and general well-being, most were really positive, especially with DACA, was really positive. But over time, because DACA doesn't have a path towards citizenship, over time, some of those gains were reversed, right? For communicable diseases and early access to preventive health services and routine care that we saw in Australia, they were really mainly positive. The type of inclusive policies that we came across are listed. The list studied was sanctuary cities and sanctuary areas. And in terms of location, most of the studies were done in the United States, very few in Europe and in Australia. So for categories of migrants, most of them were undocumented, right? We didn't see a lot around labor migrants, just one article, and a few on newly arrived individuals. And in terms of origin of migrants, there were nothing on sub-Saharan African migrants. Most of the work were actually mixed. heavily on Hispanics, but little on, others. So I work with Dr. Golan at Columbia University, and we were able to put together the quality, assess the quality of the quantitative studies. And we found that, this very big strength of this work was that most of the quality of the article were either low, the quality of article bias for the article were low or moderate, which makes them like they're all peer review articles, which really nice and recent, right? So in terms of discussion, right, we saw that there's still very few studies out there on inclusive policy, and we saw that those improvements in mental health and over time the reversal. So we need to find long-term solution to, removing white supremacy, either in form of immigration or whatever status it comes in. Yeah, some of the unanswered questions that we had were looking at epigenetic level and molecular level. What is out there? What can we do? How can we compare inclusive and exclusionary policy? Apart from the global north, what about the new emerging non-traditional migrant destination? How can we do studies in that? What are the kind of inclusive policy in those places? Well, there was equally a mismatch between policy on paper and the reality, right? So, and more importantly, there's this debate about termination of Dakhate possibly by the Supreme Court. We don't know how that's going to, because according to the Association of American Medical Colleges, over 27,000 healthcare professionals in the United States are on Dakhate status. So if the Supreme Court terminates that, how, what's the fate of this individual? Some of them actually on the front line fighting COVID-19 as we speak. So for my conclusion is that despite the anti-immigrant, rhetorics that they bring drugs, they bring crimes, they are criminals, there are still inclusive policies emerging at subnational and national level that are actually helping migrants. And we strongly believe that the continuous investment in this inclusive policy would help in reducing the unintended and intended consequences of unequal access to healthcare to these individuals and further global health development goals. And I want to quickly thank everyone that's actually helped me through this journey. My F1 visa was canceled, but it kind of helped me to understand what it is to be an undocumented immigrant. So it was actually a blessing in disguise that the University of Washington canceled my F1 visa, because I couldn't have actually imagined what people are going through and are being branded lazy, not wanting to support, which is not true. So, and until all of us are free, none of us is free. Thank you so much.
All right, thank you very much, Obiora. It's nice to see you putting this together. A big thanks to your thesis committee, because it's been, this is one of the theses that's been done long distance well before we had our long distance requirements here. Let's see, any specific questions? This is from Aaron. What is behind your point that policy on paper is different from policy in reality? How did you come to that conclusion?
Yeah, so that's a good question. Thank you, Aaron. So I went through some articles on policies, inclusive policies that was established for immigrants in France, and I discovered that there's one, there's a policy in place that says, oh, immigrants are welcome. We have this program, the CME for them, they're supposed to be working effectively. But when they show up to receive care, either the providers do not want to take the kind of policy, insurance policy they have, because they're paid less by the government, you know, or the providers are running away from, immigrants, discriminating against them and saying that some of them, they have HIV, so they don't want to contract the virus. So part of our recommendation was having some kind of training for healthcare providers, that will help them in their cultural humility, emotional intelligence, and being sensitive to others. I'm happy to share more insight on work by Dr. Powell here at Berkeley that showed a lot of work on ordering, when we order people and put them into caste system. Part of the colonialism and the white supremacy mindset, which we all have to let go of. Even at ivory towers like UW, University of California, we have to really call these things out and be frank with ourselves. It's a time for a reality check on how we order other people.
Thank you. Nura, how are we doing for time?
We're done.
We're done. Well, thanks, Obiora. It's good to have you coming back, and we're very proud of you. Nice work.
Thank you so much.
Good job.
Yeah.
Okay. Next we have Kevin Ikuta. Kevin.
Yep. Just want to make sure you can see my screen.
We can see it great.
Great. Yeah, so my name is Kevin Ikuta. I am part of the Global Health Metrics MPH track, and I'll be presenting my thesis from associated to attributable burden of sepsis. My committee is Mohsen Nagavi and Rafael Lozano. Okay, so my thesis is a secondary analysis of the global burden of disease study. The GBD study produces estimates of, among other things, cause-specific mortality for every region and country in the cause of death analysis. It adheres to the principles of the International Classification of Disease, which dictate that each death is attributed to a single underlying cause of death. In practice, it looks like this. A physician will get a death certificate and is asked to articulate the chain of events that led to someone's death. At the very bottom, we're asked to decide what was the precipitating injury or disease that set off that chain, and that's the underlying cause of death. Everything in the middle is considered an intermediate cause of death, and historically, intermediate causes of death have been excluded from global mortality estimates from the GBD and the WHO for internal consistency reasons, such that the sum of cause-specific mortality is equal to the all-cause mortality. A consequence of this exclusion is certain intermediate causes of death are responsible for significant health loss and are excluded from these global estimates that have a lot of visibility. One such example is sepsis. So sepsis is defined as dysregulated immune response to infection, which can lead to end organ damage and death. And example of a death certificate where sepsis is in the chain would be here. So diabetes leading to a diabetic foot infection, leading to sepsis and then death. Earlier this year, we published an analysis of the GBD 2017 results describing the global mortality from sepsis. And we found that there were 11 million deaths that occurred with sepsis, representing about 20% or 1 in 5 of all deaths in 2017. This is a big number and grabbed a lot of attention, but needs to be interpreted fairly carefully. One of the reasons is there are a couple of limitations. So I think the big one is that this 11 million figure doesn't account for the severity of the underlying cause of death. That is a 90-year-old person with stage 4 cancer on hospice who happens to develop sepsis is counted as a sepsis death, even though we know that their underlying cancer is likely more responsible for that person's death. The second limitation is there's no description of burden, like years of life lost or DALYs. And the consequence of these two limitations is that it treats an otherwise healthy newborn dying from neonatal sepsis the same as this 90-year-old with stage 4 cancer. And intuitively, and from a population health standpoint, we know that there's a difference between those two deaths. As a result, an editorial in The Lancet was published titled Sepsis Hysteria that said that publishing these sorts of associated sepsis death numbers leads to inflated sepsis death numbers and leads to a hysteria. And what we should be doing is estimating the number of deaths that would not have occurred had sepsis been avoided. In other words, the attributable sepsis deaths. So the purpose of my thesis was to come up with methods to describe the attributable burden of intermediate causes of death and use those methods in a secondary analysis of our sepsis results. So to do this, I decided to use a population attributable fraction or PAF approach to estimate the attributable burden of sepsis. The PAF is a way to describe the burden attributable to a specific component of a causal chain. It's often used for risk factors, and in the GBD, it's commonly used for the attributable burden of risk factors. It requires a counterfactual of no exposure or no sepsis. And there are two primary components that we need to calculate a PAF. The first is the proportion of the population exposed, and the second is a measure of excess risk or relative risk of death given exposure. And here's the sort of algebraic representation for a dichotomous exposure of sepsis. To estimate the proportion of the population exposed, we use the previously published incidence of sepsis estimates. Then for the measure of excess risk, we used a relative case fatality of sepsis and non-sepsis admissions. So we looked at hospital data, we identified sepsis admissions and non-sepsis admissions, then identified survivors and non-survivors of each to come up with the case fatality, and created the relative risk stratified by age, sex, location, year, and principal admission diagnosis. We then modeled this using Health Access Quality Index, sex, and age as covariates. And once we had the proportion of the population exposed and the relative risk, we created the PAF and applied the PAF to deaths and YLLs, or years of life lost, for each age, sex, location, and cause. The data inputs we used are here for the excess risk measure. So it's 10 countries representing more than 250 million total admissions. 8 million admissions had sepsis, and it covers more than 30 years of hospital data. The top line results are here. So on the left, we have the 2017 associated sepsis numbers that were previously published, so 11 million total deaths. On the right, we have the attributable estimate of sepsis deaths. So 3 million deaths attributable to sepsis, representing about 5 million total deaths for 2017. So when we look at sepsis deaths, only about a quarter of sepsis deaths are actually attributable to sepsis using our methods. And then looking at years of life lost, we estimated 192 million years of life lost attributable to sepsis. When we break it down by super region, we see a couple of patterns. High income Europe and Latin American super regions have historically had low burden and continue to have low burden, whereas sub-Saharan Africa and South Asia have historically had high burden of sepsis and continue to have a high burden of sepsis. This is more clear when we look at a map with country level results. We see sub-Saharan Africa with a high burden of age standardized years of life lost compared to high income in Europe. Next, we can look at the age and sex distribution of attributable sepsis deaths. And here we see that more than half of all attributable sepsis deaths are occurring in children under the age of 5. And most of these deaths are occurring in sub-Saharan Africa and South Asia. In our original sepsis paper, we described a disparity between high and low sociodemographic index countries, where the higher the SDI, the lower the rate of sepsis deaths. And that's shown here in the lighter blue line with circles. When we look at the attributable burden of sepsis, that's shown here in the darker blue line with triangles. We see a steeper slope suggesting that that disparity is accentuated when described in attributable sepsis death space. So some of the takeaways, sepsis is responsible for considerable health loss in sub-Saharan Africa and South Asia in particular. By measuring the attributable burden of sepsis, we magnify the disparity in sepsis outcomes between high and low SDI countries. Attributable sepsis deaths disproportionately affect children under 5, which leads to a high YLL burden. Then continued efforts at infection prevention and infrastructure building to prevent and better treat sepsis when it occurs are needed, with a particular focus in sub-Saharan Africa and South Asia. Some of the limitations that we should address are the PAF relies on the proportion of a population exposed. For this, we use the incidence of sepsis, and that assumes that there's no reincident cases, so could overestimate the proportion of population exposed. And we don't resolve the confounding effect that the severity of underlying condition has on the risk of sepsis and the risk of death. And then to identify sepsis, we relied on ICD codes, which risks misclassification. And then for relative risk, we measure relative risk for hospital admissions with and without sepsis. This would underrepresent the risk of sepsis not presenting to the hospital, but there's really no data that's available on the risk of death with sepsis that isn't presented to care. So a number of people to thank: my thesis committee, the GBD, intermediate causes and sepsis team, and the infectious disease team at the University of Washington, who have been my mentors. And I'm happy to answer any questions.
All right, thanks very much, Kevin. Very nice
Good job.
presentation. Very interesting stuff. Any chat questions yet? I don't see anything. I'll start out with a question, sort of a double question. I was actually kind of surprised to see the attributable risk of sepsis so high in kids in sub-Saharan Africa, particularly because diagnosis is hard. It's hard for me to imagine that so many of those deaths have ICD diagnoses. And although you can imagine lots of deaths in the neonatal period from sepsis, particularly in the first week and month of life, the sepsis that I would imagine in the first 5 years outside of that is it seems more likely to be malnutrition related, which, but I don't know. And so I'm just curious as to what you think the dynamics of that huge number that you showed for under 5 sepsis deaths in South Asia and Africa.
Yeah, well, I think a lot of those deaths end up being, like, the underlying cause for those deaths tend to be lower respiratory infection and diarrhea. Though malnutrition is a common underlying cause of death and risk factor for death if someone develops LRI and is undernourished or malnourished. Yeah, and to comment sort of on the data of sub-Saharan Africa and South Asia, most of those are modeled. So there was no hospital data represented in South Asia or sub-Saharan Africa. Yeah, so that's modeled based on the Health Access Quality Index, and then the underlying cause of death and that relationship between those two.
Right. Okay. Let's see, here's a question from Bernardo. Nice work. Would it be possible to compare the estimates of sepsis mortality based on all causes, your method, versus only underlying cause of death in different countries? Would it reflect differences in registry of cause of death as well?
So sepsis isn't an underlying cause of death. It necessarily is a intermediate cause because it relies on infection being present and for sort of setting off that cascade of inflammation that leads to sepsis. So yeah, our sepsis estimate is stratified for each individual underlying cause of death. Yeah, I'm not
Okay.
sure I understand the question.
Here's a question from Raphael. How much of your results are driven from access to and quality of the health services?
Yeah, I mean, that's the principal covariate that we use. So it's the biggest driver for I think the disparity that we see across a specific underlying cause of death. The other driver for the disparities are the distribution of underlying causes of death and the age distribution of deaths in each individual country. So when looking at just a specific underlying cause of death, the biggest thing responsible for any disparity will be the health access and quality.
Okay. Time for one more?
Nope, we're at time.
We're out of time. Okay, sorry, Nora. Okay, well, thanks very much, Kevin. This is really fascinating. I've got some other questions that I'll ask you offline.
Okay, thanks.
Good
Great.
job, Kevin.
Take care. All right, for the last presentation of the day, we have Wilson Hammett. Wilson.
All right. Let's see. 1 second. This is taking a second to share my screen. There we go.
You okay, Wilson?
Yeah, 1 second. I'm having trouble sharing my screen. 1 second.
No problem. I see there's a lot of current students here, first-year students. I'm very glad you're able to join this session. I
Yes,
hope you're
I'm amazed. We got
learning a
40 people
lot,
here.
and yeah, exactly. So this is great.
Yeah.
Okay. Here we are.
And Wilson, can you also put your video on for you so we can see you presenting?
Sure.
I should have asked everybody else too.
It's unfair to do that now.
I know it's unfair.
Yeah. Here we go. There we go. All right, can you see and hear me now?
Yep, looks good.
Yes.
Great.
Thanks, Wilson.
All right, so I'm Wilson Hammett, and my thesis is entitled Transdiagnostic Psychological Intervention, CETA, Improves 3-month HIV Treatment Retention by over 14% in Mozambique. And I'd like to start by acknowledging my power, privilege, and positionality. I'm a white, master's-educated, US-born woman who was not in Mozambique during the devastating Cyclone Idai, which hit the study setting in Sofala province, Mozambique, in early 2019. Moving right into background, common mental disorders, or CMDs, an umbrella which includes depression, anxiety, post-traumatic stress, substance use, and suicidal ideation, are common among people living with HIV and are associated with poor HIV treatment outcomes, such as reduced probability of initiating treatment, lower probability of viral suppression, more rapid disease symptom progression, and there is a need for increased focus on addressing CMDs among people living with HIV in areas with high HIV-positive populations. The Mozambican context is uniquely situated to benefit from a potential scale-up of an integrated mental health intervention in public HIV care. So challenges include that 12.6% of the population of Mozambique is living with HIV/AIDS. Only 68% of those who initiate antiretroviral therapy, or ART, are retained in care at 12 months. So that it's 16% of the population of Sofala province, the study setting, are living with HIV/AIDS, and only 60% are retained in care at 12 months. The rates of viral suppression are also largely unknown, and there is no formal link between mental health care and HIV care currently. So HIV patients are not routinely screened for CMDs. Many opportunities exist in the Mozambican system, however, including that the Ministry of Health has already deployed psychiatric technicians to many facilities around the country in each of the 133 districts. So efforts to scale up mental health services are already underway. Mental health treatment is also fully insured, and HIV counseling exists for the newly diagnosed, and HIV treatment occurs in the primary care setting. So this creates several opportunities. few LMICs have scaled up treatment for CMDs and or evaluated the effect of such treatments on HIV treatment outcomes. So the intervention implemented and evaluated in this study is known as the Common Elements Treatment Approach, or CETA, developed by Shannon Dorsey of UW and Laura Murray of Johns Hopkins. CETA is a transdiagnostic, task-shared, individual psychological intervention developed specifically for LMIC settings. It's flexible and modular, making it easily tailored to an individual's comorbid mental disorders. CETA has been shown to be successful at reducing symptoms and disability associated with CMDs in several LMIC settings, including Iraq and the border of Myanmar and Thailand, and is a subject of several ongoing trials. CETA Mozambique is the first time this approach has been evaluated for its effect on HIV treatment outcomes. So the aim of this study was to evaluate the integration of CETA into public HIV care in Sofala, Mozambique, and evaluate initial programmatic effects on mental health symptoms and retention in care. Moving on to methods. The pilot implementation of CETA Mozambique began with training of lay counselors and local supervisors in March 2019. Counselors then continued training using the an apprenticeship model through April 2019 and began treatment with full client loads in May 2019, with additional ongoing training from expert CETA trainers and local supervisors. The pilot was renewed for another year in September. So my evaluation of CETA is a descriptive analysis of the initial results of the pilot implementation project, which was prohibited from directly conducting research. So data collection was conducted in Beira between May and September 2019, which was the end of the initial pilot period. CETA Mozambique was implemented in 5 public primary care facilities. All recently diagnosed HIV positive patients were screened for CMDs using a validated composite screening tool. Those who showed clinically significant symptoms of one or more CMD were offered enrollment in CETA, and upon enrollment, patients were administered a more comprehensive screening tool to assist counselors in determining course of treatment. And then this screening tool was again administered at each CETA visit with a counselor to track treatment progress. So all CETA patients screened, enrolled, and treated from May 1st to September 31st of 2019 were included in analyses. Matched patient identifiers were used to connect CETA data to HIV treatment data obtained from study facilities. HIV treatment data was included through October 31st to account for those who enrolled in CETA near the end of the pilot period. Overall facility averages for 5 participating health facilities were obtained from CDC Mozambique and were used for a programmatic comparison group. I used descriptive analyses to summarize demographic information of the study population, to determine mental health symptoms at baseline, and to compare HIV retention among CETA enrolled patients to the overall facility averages. So I used CETA Mozambique's definitions of 1 month and 3 month retention in these analyses. Looking into results, 59% of the 250 HIV positive individuals screened showed clinically significant symptoms of CMDs and thus met criteria for enrollment. Of those that met the enrollment criteria, 92% enrolled in CETA. The median age of those who enrolled was 30, and 61% of those that enrolled were female. Looking at improvements in mental health symptom severity, we saw that at baseline, 10% of the study population showed current suicidal ideation, and 2% demonstrated other violent ideation. In those that attended 3 or more CETA visits, however, 0% showed either suicidal ideation or violent ideation. And at baseline, the average composite mental health symptom score was 19.8, which was reduced by 58% in those that attended 4 or more visits with a CETA counselor, and by 92% in those that attended 7 or more visits. Looking at retention in HIV care, we saw that 97% of those that enrolled in CETA also initiated antiretroviral treatment. 1 month retention for CETA was 69%, as opposed to 66% for all HIV positive patients. And 3 month retention for CETA was 82%, as opposed to 68% for all HIV positive patients. After 7 or more sessions, 1 month retention was over 87%, and after 6 or more sessions, 3 month retention reached 100%. For additional programmatic comparison, we looked at the facility level and determined that 3 month rates of retention in ART for CETA enrolled patients were higher in all 5 study facilities than the overall retention averages. Moving into discussion. This evaluation helped to illustrate the need to address CMDs among people living with HIV in Mozambique. Over 50% of those HIV positive individuals screened showed clinically significant symptoms of one or more CMD, and over 10% showed current suicidal ideation. There is currently no system in place to routinely screen HIV patients for CMDs, and these results indicate a very large burden of CMDs among newly diagnosed HIV patients in Mozambique. This evaluation also showed that CETA appears to improve both mental health and HIV treatment outcomes. When delivered in routine HIV care, it appears to effectively decrease symptoms of CMDs, and it may lead to over 14% increase in retention in HIV care. The effect of CETA on retention could also be larger than we observed, as the programmatic comparison group included CETA-enrolled patients in the overall facility averages. This evaluation also highlights a need for more targeted implementation research. The majority of prior studies implementing mental health interventions among HIV-positive populations in LMIC settings evaluate the effect of these interventions on mental health outcomes, or focus on implementation outcomes related to delivery, not on the intervention's effect on HIV treatment outcomes. There is a need for implementation research targeting scale-up of task-shared interventions addressing comorbid CMDs among HIV-positive patients in these settings. So in conclusion, we found that a large proportion of newly diagnosed HIV patients showed signs of mental distress at diagnosis. CETA may be a promising approach to improving HIV treatment outcomes while also treating mental health symptoms among HIV-positive populations in LMIC settings. And future implementation research should examine the effectiveness of this intervention in a larger, well-controlled programmatic trial setting. I'd like to acknowledge the support of the implementing partners and funders, the support of my chair, Brad Wagner, and committee member Pamela Collins, my reviewers, and study investigators involved in this project who have all been mentors to me along the way. Thank you.
Very nice presentation, Wilson.
Great job.
It really showed a lot of potential benefits from CETA. A couple questions already. Let's see. I think we have, where do we start here?
Start with Deepa.
With Deepa, there we go. Okay, Deepa, nice solid work, Wilson. What are the next steps for CETA in September? Is there a plan to expand or scale up?
Yes, so CETA has continued. So September 2019 was the end of the initial pilot period, and it was renewed for another year. There are conversations with several implementing partners to expand, where Brad is actually the best person to ask about that, since he's been involved in applying for additional funding to expand. But we presented to, when I was in Mozambique in November, we presented to the Provincial Health Directorate and to the Ministry of Health, and there's quite a bit of interest in expanding CETA within Mozambique.
Excellent, nice. This is from Catherine Kemper. How was the CETA program adapted or modified in the Mozambique context? Were results similar to the CETA projects in other countries?
I'm unclear on exactly results similar to other trials, because CETA Mozambique is quite different. It was adapted quite a bit. We changed both the tools themselves. We changed a lot of the language. We spent from September of 2018 to when training happened in March of 2019, working with Shannon Dorsey and with the team in Mozambique to adapt the materials themselves to really fit the language and cultural context of Mozambique. And then the actual system itself of how patients move through the pathway of CETA changed quite a bit, because it's the first time it's been integrated into this existing healthcare setting. So our counselors themselves did the screening in the HIV treatment department in a public healthcare facility, and then also connected with psychiatric technicians in the case that patients showed signs of serious mental illness or suicidal ideation. So it created this on-site in a public health facility, this screening and then implementing CETA. And then we also adapted after Cyclone Idai. We adapted because space was an issue. Space is already an issue in several of these facilities, but was particularly short in the months after Cyclone Idai. So counselors ended up meeting many of their clients at their homes or outside their homes or in the community somewhere to make it easier to meet with clients.
Great. And time for one more question. Let's see, this is Pamela Collins. Wonderful presentation, Wilson. Do you have any data on what helped people adhere to CETA?
That's something that we have a lot of questions about, and I would like to know a lot more about. I did some qualitative interviews while I was in Mozambique, and I'm currently analyzing them for a different paper. So I will have more on that soon. But we tested out a few theories while I was in Mozambique on trying to make sure that contact between counselors and clients was pretty constant. And then also meeting clients where it was most convenient, most private for them. Both were qualitatively determined to be helpful.
Noura, got time for one more?
Yeah, 2 more minutes. There's 2 questions.
Okay, so this is from Isabella. Fabens, thank you. Did you end up including qualitative results in your thesis? If so, could you share some of what you learned? I'm not sure if I missed it.
So as I was just saying, it's not included in this particular paper, but I did conduct in-depth interviews with counselors and with clients in Mozambique last summer. And so that's currently being analyzed and will be included in a future paper.
Any pearls you can give us right now?
I hesitate to, but I think that most of the counselor interviews and supervisor interviews that I did were incredibly thankful for something, just putting mental health into discourse. Like people, a lot of the counselors started using some of the tools that were taught in their own lives with their friends or their family members, and just making mental health less of a taboo thing to be talking about. So that was a very widely shared thought.
Okay. And then finally, Stelio Tembe asks, one of the problems related to reduced number of psychiatric technicians and large number of patients. How does CETA help address the issue of the number of technicians?
Right. So we this pilot implemented CETA in facilities that had a psychiatric technician on staff in that facility, which is not necessarily the case in all facilities in all of Mozambique, but that it did alleviate pressure on those psychiatric technicians. So taking some of the common mental disorders off of their caseload. So and then filtering through those with the more serious mental illness or with suicidal ideation to those, referring those to those psychiatric technicians for treatment.
Excellent. Well, thank you very much, Wilson. This is a great presentation, a nice one to finish off the day. Congratulations.
Good job.
And a huge thanks to all of you presenters, all 8 of you. You really did a great job. You set a very, very high bar for the rest of you. Thanks to all of you who participated. We had probably 50 or so or more folks show up, and I think that was really great. And also a big thanks to the faculty, students, staff, family, and friends who supported our students through this very, very tough and challenging but productive thesis process. So congratulations to everybody, and take care. Thanks again, Noura.
Great job. Thank you. See you all tomorrow, I hope, starting at 10 a.m.
10
all right, take care.
Okay.
All right, take care, everyone.
Have a good evening. Okay,
Thank
bye.
you, everybody. Bye.
Bye.
Bye.